So we go on to the first set of talks, which is irregular astigmatism, post-keratoplasty, and keratoconus. And discussing these are our speaker is Dr. Charuta Puranik, who's a senior consultant ophthalmologist, is a cataract and a refractive specialist from KIMS Hospital, Secunderabad, and her talk is going to be monofocal IOL is the way to go. Now, contradicting her is going to be Dr. Shreyas Ramamurthy, who's a consultant cataract, cornea, and refractive services at the Eye Foundation Group of Hospitals. And he is going to say that toric IOL is the answer in more often than not in keratoconic or eye or in post-keratoplasty. And giving her expert viewpoint on this is, again, we will be calling Dr. Prema Padmanabhan. And so on to you, Dr. Charuta. Let's hear from you about why you feel monofocal is the way to go.
So thank you for the opportunity, Dr. Chitra, and it's a very interesting and challenging topic. So I'm going to delve right away into the topic. So I'm going to start off with a case. This is a 24-year-old female patient who presented to us with the left eye like this post-DALC, 6 years post-DALC done for keratoconus in some other hospital. She had also suffered from microbial keratitis. As you can see, there is a scar over here. And this is her refraction in the left eye, -10 sphere, -3 cylinder at 25 degrees axis. With this power, she was correcting to 612, but obviously, if you can see, there is an isometropia in both eyes. So we went ahead, we did, she also had a steroid-induced cataract in the eye. And we went ahead and did the IOL master, which is showing a difference in the keratometry values, which from the topography scan. And we also did the specular to complete the evaluation preoperatively. Based on this value and based on the keratometry values that we had during refraction, we decided that the spherical equivalent power was somewhere between 2 and 10 because of the axial length, considering standard K and also the K that we took from the IOL master. So therefore, a spherical equivalent power of plus 7.5 was taken in between. And we had obviously counseled the patient that she would have a refractive surprise. I planned a sclerocorneal tunnel incision in order to create a surgeon-induced astigmatism of 1.5. And then at the end, this is her last follow-up. You can see there is a piggyback IOL of the toric IOL along with a sphere of +2. So totally altogether, post-op day 1, she was 6.9, and now 1 month post-op, she's 6.6 parts. So this is, I'll come back to this case later on. This is to say that the grapes are not sour. Now I'll come to the other half, that irregular astigmatism in keratoconus, what are the facts that we know? And Dr. Chitra has asked me to keep it to a very theoretical and evidence-based talk. So here goes the review of literature that we have. Now we know that IOL power results of cataract surgery in keratoconus have long been suboptimal. And with significantly fewer patients achieving within 1 diopter of the intended refractive target, even with a monofocal lens. And a hyperopic shift following the surgery is also commonly described, particularly in patients with more severe stage of the disease. And we have a myriad of challenges which we face while selecting a suitable lens. That is standard IOL calculation formulas predict effective lens position based on the parameters of a normal eye. Whereas that cannot happen in these cases because of the abnormal relationship between the anterior and posterior corneal curvature, the varied anterior chamber depth and axial length, and also standard keratometric indices depend on the predictable ratio between anterior and posterior corneal surface, which is progressively being disrupted in keratoconus. Next is the question of which K. So simulated K value is actually derived by taking radius of anterior corneal curvature and a standard keratometry index of 1.3375. It assumes a fixed ratio. In keratoconus, this ratio is altered as said before. Now, Kamia et al. Calculated the total corneal refractive power, TCRP, using ray tracing methods. And this considers both anterior and posterior corneal surfaces in keratoconus, and he compared it with SIM-K value. As you see in the graph, the degree of variation between SIM-K and the TCRP values in keratoconus eyes is markedly high as compared to those in normalize, and this difference becomes more evident as the disease progresses. So likely the cause of hyperopic refractive error post cataract surgery in keratoconus patients is due to the overestimation of this TCRP. Another to add to that is the decentered cone, which doesn't coincide with the visual axis. What else? So rotational stability is actually a major endpoint analysis of the toric IOL. And it greatly depends on capsular bag size and axial length and associated myopia. So theoretically, all patients with keratoconus who have axial myopia or should be actually prone to IOL rotation, although there is no case report which is actually reported this. Now, residual astigmatism can be produced due to rotation of the toric IOL post-surgery. Again, let's look at the pooled studies which we have. So this is data from 2020, and Kane et al. have studied 147 eyes of 147 patients for all stages of keratoconus, and the keratoconus Kane formula actually did very well in all stages. And to avoid hyperopic result, which was mentioned before, they suggested some corrections also, that is in mild to moderate keratoconus. There should be no correction in the Kane keratoconus formula. In the moderate, you can target myopia of 0.75 to 1.5, and for severe cases, -2 to -3 should be aimed. Now, this is the only study which has actually compared normal IOL formulas with IOL formulas that are specially designed for keratoconus patients. And with all this in mind, we are only talking about monofocals here. Now, we have some latest data from 2023 again, wherein Ling et al. Have upped this number and compared 160 patients. The accuracy and outcomes of different intraocular lens power calculation formulas in keratoconus with monofocal IOLs and with toric IOLs. So in these 160 patients, 136 received the non-toric lenses and 24 received the toric lenses. That is, the lesser number itself says their preference. However, if we look more carefully at the data also, the patients who underwent the surgery, in both the groups, the mean refractive error, predicted refractive surprise was not different between the two groups. That is the first and foremost pointer. Next, if we go to see the subgroup analysis, in all the subgroups also, there was not much difference between the average post-operative
1 minute left,
spherical equivalent and the final CDVM. More notably, if you can see, 7 of the patients were who received the monofocal IOL stopped using the RGP after the surgery, whereas all 3 patients who got the toric lenses continued their RGPs even after surgery. Another interesting, I was searching for some interesting data, that is in keratoconus, what is the contrast sensitivity or higher order aberrations. And this is a group, Sneer et al., who have assessed correlation between wavefront aberrometry and contrast sensitivity in patients with keratoconus. And they have also sub-analyzed patients with keratoconus having 0 logmark. So there were significant differences between groups between higher order aberrations for trefoil, total coma, trefoil, and spherical aberration. The contrast sensitivity is again significantly lower in keratoconus compared to control groups, and significantly lower in keratoconus with a visual acuity of 0 compared to the control groups, which means that even if you have a 6/6 vision acuity, your contrast and your higher contrast is going to be lower than somebody with a normal, and your higher order aberrations are probably going to be higher than somebody with a normal eye. So why is this important is, this is another case series wherein the changes in astigmatism and corneal higher order aberrations after phaco with toric IOL implantation for mild keratoconus was checked, and they showed that the corneal higher order aberrations were changed from 0.47 to 0.52 post-operative, which is not statistically significant, but however, it was a slight increase in the HOA. Now, if we again see that what happens if you make a mistake, if there is a slight rotation or if there is a slight error in calculation, what happens? Residual astigmatism, if it is greater than expected, then aberrations tend to be higher. So this patient is obviously going to be intolerant to higher order aberrations already from beginning, and you are also subjecting him to a probable increase in the HOA. Again, contrast sensitivity. This is a repeat thing. Now, what else do we not know? What is the comparative value of such measures, that is contrast and HA toric versus monofocal in keratoconus? We don't know what is the level of spectacle independence comparative value between these two. I didn't find any literature about quality of life and any literature about secondary interventions that these patients underwent, which would be something that I would want to know. Coming back to the case 1, and this is what the questions that were asked to me, and which I obviously didn't have an answer from the relatives of the first patient. Will the graft reject? What will happen if the graft rejects? What will happen if there is another infection? And this is post keratoplasty patients. Obviously, even though I put a piggyback lens, the patient is now 6'6", and another keratoplasty was definitely not justified in these patients. But these are the variabilities that the patient will face in future. So to conclude, there is no change in the corrected distance visual acuity between toric and non-toric. There is a lesser margin of error allowed in the toric IOLs for keratoplasty. Post-keratoplasty fate of the graft is a challenging situation, and further studies are required for real-world scenarios as to how the patients feel after a toric versus after a monofocal lens. Thank you for your patient listening.
So, Dr. Charuta, that was a very crisp talk, very informative. Before Shreyas takes his talk, I just want to tell that after the expert viewpoint by Dr. Prema, I would like to take a question with Dr. Namrata and Dr. Minu Matan. So on to you, Shreyas.
So good evening, everyone. What I would try to do over the next few minutes, Dr. Charuta extensively covered some of the literature. While my aim would be to not just say that toric IOL can be used in every keratoconic and every post-graft patient, but it is to merely try and highlight where we can use them and what are the factors that we need to keep in mind if we are using a toric IOL in these conditions. Now, we all know a toric IOL is preferably only for orthogonal astigmatism. And what we mean by that is a regular astigmatism in both magnitude as well as direction. That is repeatable measurements even in terms of axis. Now, this is where in patients with keratoconus, it becomes a little bit more challenging. But before broadly saying keratoconus, we also need to delve a little deeper whether the patient has a central cone or a decentered cone, because you are more likely to get a repeatable K reading both in terms of direction and magnitude in a more centered cone than a decentered cone. Was the patient a previous RGP or ROSK user, and are they willing to continue wearing contact lenses after cataract surgery? If that is the case, then the debate ends here, because then monofocal is the answer, because any irregular astigmatism is going to be taken care of by the contact lens itself. But very often in our cataract surgery patients, the diagnosis of keratoconus can also be incidental. That is, they've had a stable keratoconus right from the age of 20. Now they have presented for cataract surgery at 65 or 70. They are not really been bothered extensively by their keratoconus itself, and they've been wearing glasses till a particular age. So these are patients where the cornea can be further optimized and can undergo a cataract surgery. So this is just one such example. These are some of the points which Dr. Charuta had already covered, where she mentioned that poor repeatability and accuracy can be a concern. The ratio between the anterior and posterior cornea is not fixed. And these are things, and where do you measure, whether you're exactly measuring at the vertex or whether you're measuring the steepest point. All these are the primary reasons why you get variability in measurements. But having said that, if you can optimize the cornea, improve the repeatability of the K reading, it is worthwhile doing so in these patients before taking them up for cataract surgery. This is just another example of a patient who presented for cataract surgery, but incidentally had keratoconus on examination. We first subjected this patient to a topo-guided PRK, and once this cornea regularized and we had a repeatable K reading, we could very safely take them up for a toric IOL implantation. A little more advanced cone, this patient was not interested in wearing contact lenses, had not been wearing contact lenses, had a poor UCVA even before the onset of cataract surgery. Now, this was an opportunity to optimize the surface before going ahead with the cataract surgery. Intracorneal ring segment was done, the amount of astigmatism reduced, the apex flattened, Subsequently, we got a more repeatable K reading, both in terms of magnitude and direction, and then went ahead with the cataract surgery. The video itself is not much. It's just to merely highlight, in case a laser cataract is being used post intracorneal ring segments, the edges can cause a diffractive effect, and therefore it's important that you gather the rexes and ensure that it is there are no tags before you go ahead with the cataract surgery. The rest of the surgery is pretty straightforward. So in case the patient is willing to continue contact lenses, like I said, please continue, because if you put in a toric IOL, when you put a contact lens on top of a toric IOL, you'll end up uncovering the astigmatism, and the patient will require glasses on top of the contact lenses to correct whatever cylinder has been induced by the toric IOL. But most of our cataract surgery age group patients are less likely to wear contact lenses in the post-operative period, especially if it's being prescribed to them for the first time. So in these cases, a toric IOL with aiming for a slightly myopic outcome is important, but an adequate counseling is necessary. Again, outcomes are very, very variable. You look at various studies which have looked at it based on the stage of keratoconus, whether any preoperative procedure has been done. Each stage, early stage, you could do a topo-guided PRK. A moderate stage, you could combine it with the intracorneal ring segment. A very advanced stage of keratoconus, you could do a staged procedure, first do a DALK, regularize, and then subsequently go ahead. But each of these patients can be addressed appropriately. PMD is a situation where you have less irregularity in the central cornea, and therefore the K readings are much more repeatable. However, you may have higher degrees of astigmatism, and you may require customized toric IOLs. In post-PK and DALK, it's important that we wait till we complete suture removal. It is not necessary that every single suture has to be removed. There might be situations where you've reached an acceptable level of astigmatism. And let's say for this example, this patient for the last 1 year had a stable astigmatism, had 4 to 5 sutures already left in situ, but these sutures were not becoming loose, were not going to disintegrate in the time period, but had developed a steroid-induced cataract. So in these patients, it's better if you remove some of those sutures which are in the opposite axis, you might actually end up increasing the amount of astigmatism. And therefore, it is just better to leave them aside and go ahead with the cataract surgery itself. This is another scenario where a patient post-DALK had also developed a steroid-induced cataract. And as we know, in DALK, the chance of rejection is very less. The long-term survival is very, very good. And these are patients where even higher degrees of astigmatism can be corrected very, very comfortably. So this was a DALK for post-keratoconic patient and had a significant residual astigmatism, almost 9 diopters of astigmatism. And if you implanted a monofocal IOL, even wearing glasses for such a high cylinder would almost be impossible. So the aim here is to really debulk the amount of astigmatism. We are not aiming at emmetropia. This is a customized toric IOL and from the Care Group lens. And this Ultima Smart Toric can correct almost any amount of astigmatism that you require. So by debulking the amount of astigmatism, we are now able to reach a stage that the patient has a very, very acceptable residual error, which they can now wear comfortably with their glasses. So to conclude, toric IOL is a definite possibility, even if the patient has irregular astigmatism. It's important that you meticulously select the case, do a careful planning, optimize the surface before you take them immediately up for a cataract surgery. And again, counseling the patient, explaining to them the purpose of doing a toric IOL in these patients is really to debulk the cylinder, provide a better uncorrected and best corrected visual acuity, whereas we are not aiming for within plus minus 0.5 diopter like we do for our regular set of cataract surgery patients. Thank you so much for your kind attention.
Thanks, Shreyas. That was again another wonderful talk. So let's look forward to what Dr. Prema has to give her expert viewpoint.
Thanks, Chitra. It was a pleasure listening to both Charuta and Shreyas. I would call this actually a debate because the two views were not really, contradictory to each other. I think both of them have actually positioned the two choices that were discussed, the toric IOL and the monofocal IOL. They have positioned them appropriately because there is a place for each. As Shreyas rightly said, if it's in a keratoconus, if it is a central cone, or if you can bring the astigmatism to closer to a more regular astigmatism, then there is just no, you're actually, the patient would benefit from a toric IOL. Post penetrating keratoplasty and keratoconus are two situations which have something in common, but they are slightly different in another respect. What they have in common is that they both represent situations where the challenge lies in the corneal optics, and you're using the cataract as an opportunity to correct the corneal optical errors. But when you look at irregular astigmatism, we have to understand that it consists of lower order astigmatism, it consists of higher order astigmatism, some amount of coma that presents as astigmatism, some amount of spherical aberration that presents as a defocus. And so there is an interplay and quite a dispersion of various aberrations that interact with each other and result in the visual disability. So to find out how much of that astigmatism is really a refractive, regular astigmatism, and how much can be corrected with a lens and how much will remain uncorrected is important. And as Shreyas rightly pointed out, counseling these patients is extremely important. For them to understand, it's not like other cataract surgeries, for them to understand what they can expect, and more importantly, what they cannot expect after surgery is an important part of it. These patients would probably go to any cataract surgeon, but it is best to refer them to a place where the corneal diagnostics are available. Simply because these patients require a more detailed corneal examination. For a grafted patient, I would look very closely at the graft, and as Charuta pointed out, doing not just a specular microscopy, but to examine, but to know the primary pathology for which the graft was done, for you to be able to predict whether this patient is likely to require another graft in the future. Because if he does, then this entire exercise is futile. These are eyes with already complicated optics, and now you're introducing yet another optical element in the form of an intraocular lens. So while it has the potential of correcting some of those errors, it also you also run the risk of complicating the optics still further. So one should be careful about this. Some amount of, as I said, interplay between aberrations, like some amount of coma with some amount of astigmatism actually improves vision. But this is more easily demonstrated in an optical bench than in an actual patient. So I think I would say that the way Shreyas has made an algorithmic decision tree about when he would use a toric lens and when he would still opt for a monofocal lens is an important thing. And let's not forget that at the end of the day, contact lenses are always there for post-PK eyes or post-ketoconic eyes to improve the quality of vision. And that's all I have to say.
Yeah, thank you very much. Beautifully summed up, Dr. Prema. I see that Dr. Namrata Sharma is not there. So I think I would, Dr. Nikhil or Dr. Praveen, I would take a question from you. Oh, Namrata is there. Good. Dr. Namrata, now can you tell us, there's a complexity in getting the K value. So do you have a particular go-to instrument to measure the K in a keratoconus patient, or would you like to check it on different devices? How would you do it? Are you there, Namrata? I think she's not connected somehow. I would, since there are other cornea guys here, I thought I could take the thought of Dr. Nikhil or Dr. Praveen, if you all are there. Both of, yes, Dr.
I'm here.
Yeah.
Hi, Chitra, and very nicely summarized by
Right.
Dr. Prema. But I actually had a question for either of you, Charuta or Shreyas. At what stage not a cataract surgery, but doing a transplant and then doing a cataract surgery after the transplant? I mean, what kind of case on the scan or on topography will prompt you to do that, to take that approach?
Do the transplant first and then the cataract surgery, you're saying, sir?
Yes.
So predominantly, I restrict it to either a dystrophy where the cornea has to be corrected, or advanced keratoconus where the patient is not willing to wear scleral contact lenses in the post-operative period. Probably these are two situations where I would do a graft first, wait for the K reading to stabilize. Of course, all this is keeping in mind that the cataract is not too advanced or you don't have a mature cataract already. But then if it's a relatively early cataract, then the cataract can definitely wait, and we can probably do a DALK in these advanced keratoconus, wait for the BCVA to improve, the overall surface to improve, and then consider a cataract surgery. Maybe a year or so after the graft.
Yeah. So as far as the K value measurement, which I'm coming back to again, I know it is a huge challenge in a keratoconus. So if the K is, the cornea is fairly regular within 3 millimeter zone, or would you look at the EKR value, or would you rely on the IOL master? I'm not talking of advanced keratoconus, mild to moderate keratoconus. Which would you look at? The EKR maps, will you trust the IOL master for the K? The pentacam? Shreyas, Charuta, Dr. Meenu Mathan?
Any two
I think-
which are similar to each other. That's what I followed for the first case also, or generally. So
I think it's important to have measurements from 2 or 3 devices, and more importantly, to the extent possible, have repeatable measurements. And of course, the integrated K calculator also can be used, where you have slightly varying values from 3 different devices. Then it gives a certain weightage to each of these values, and gives you the best possible result. Again, these are obviously, like was already mentioned by Prema Madam as well, we are not aiming at absolute refractive accuracy. There is a significant possibility of having some residual error. What could be the best option and how much we can debulk the refractive error is probably what we are discussing.
And just one last question, Dr. Meenu, the formulas which you're looking at, I know we are cataract surgeons and this is so typically a cornea topic. There is this SRKT, which seems to be also popular, surprisingly. And there is this Keynes formula, there's Barrett's formula. Both Namrata and Meenu, just one line answer. Which would be your choice of IOL formula in a keratoconus patient? I had a question for you, Namrata, but it got answered.
Yeah, I got disconnected.
Yeah.
I would use Keynes formula. I think for keratoconus, the Keynes formula is the one which works best. But having said this, we will, like I said, we will use other formulas also. But as per all the studies also, and in practical experience also, I think Keynes is the one which works best for keratoconus.
But why is it that in Keynes formula, I did come across that you take the anterior corneal measurements, but do not consider the posterior corneal measurements values? Is it that we would end up overcorrecting?
Yeah, because the posterior cornea is going to be much steeper than what it is when you generally would, calculate the power. And even if you look at keratoconus, the only thing is that, first, this thing that would come, the changes that would happen would be posteriorly. So that would be far more steeper as compared to the anterior part. So that is why
better to take the
anterior part is taken, because otherwise that will fallaciously give you a false K reading.
Yeah. Dr. Meenu?
I don't have comparisons of my own experience. I use only Barrett's right now, but I have to see Keynes also and see whether they're coming different, much different our scenario. But Barrett's is okay working for me for this also.
But I do agree with Shreyas that doing a topo-guided surface regularization also makes sense in these early keratoconus patients. Yes, Dr. Ramamurthy and Dr. Saurabh, we'll be taking your keynote address now. Next. Sorry for the delay. Yes, Dr. Ramamurthy.
Just wanted to add a quick word. If we are considering toric lenses, maybe the Barrett 2K toric formula would be the way to go. Of course, getting the right K readings would be a challenge, as already discussed. Very recently, Barrett has come up with a Barrett keratoconus formula, where specifically addressing the keratoconic eyes. I've heard about it. I've briefly read about it, yet to experience it. Maybe once it gets validated, then maybe that would be the formula you could consider in these eyes.
Thank you. That was well discussed.